It's an honor to welcome our esteemed speaker, Dr. Cedric von Pritchett, as our department's final Grand Round speaker of 2024. Dr. Pritchett is an internationally recognized pediatric otolaryngologist, clinical investigator, and advocate in pediatric hearing healthcare. He received his MD from Ohio State University, completed his residency at University of Michigan, and fellowship at Lurie Children's at Northwestern. He currently works at Nemours Children's Hospital in Florida as co-director of Nemours Children's Ear, Hearing, and Communication Center and medical director of the cochlear implant program. He's also associate professor with the University of Central Florida College of Medicine. His research focuses on barriers to care for children who are deaf and hard of hearing, racial disparities and inequalities in access to early cochlear implantation, and timely identification of congenital cytomegalovirus and CMV-related hearing loss. His research has also looked at children with auditory neuropathy, barriers to care, and a point-of-care assay for ZMV medication. And I was just mentioning to him, he was recently named 8 days ago, hot off the press, to the Board of Trustees of the Ober-Cotter Foundation, which is this national foundation founded in 1985 that has provided over $500 million of funding to improving listening, spoken language, and literacy outcomes for children with hearing loss in their families, which is incredible. So he is widely recognized as a fierce advocate for children identified as deaf and hard of hearing, and he's here today to share some of that experience with us and the ways in which, as surgeons, we can make a difference at the health system level. So thank you so much, Dr. Pritchett, and we very much look forward to your presentation.
Thank you, Michael, for that kind, generous introduction. Hopefully everyone hears well, and I managed to not embarrass myself with use of technology. I can ask my teenage daughters to help me, but they're not here right now. So greetings from Orlando and Florida, East Coast, and just wanted to acknowledge the privilege. Dr. Dylan Chan is a nice colleague of mine. I respect him highly in the work that he and his team are doing out there, is giving us guidance and inspiration. We thank you for that. Certainly also acknowledge the leadership of your fine institution with Dr. Muir and Dr. Rossby. So we're going to take a few moments to delve into topics that are interesting. I can't say I am the most polished expert, have seen everything, but I certainly share my experience in a part of the country that has some unique aspects for your benefits, both in your practice and in your future practice for the trainees. So let's get started. Just a couple of disclosures. I've had opportunity to work with a few of our industry colleagues and partners in the work that they're trying to do. Also serving on the EDDI Advisory Board for the state of Florida and working closely with the National CMV Foundation. But perhaps the most important disclosure is this, right? I accept the risk that as a Floridian speaking to Californian audience, I will be amongst friends here. So just a tiny bit about me. I like to think of myself as a guy with Midwest values, East Coast attitudes, and West Coast curiosity. I am happy that I have a Ford 150 truck. I'm not a big cat lover, but my wife and daughters are, and so the cats are growing on me, and I'm trying to be a supportive dad and husband. But being in Florida has given me an opportunity to try new things, right? So you learn to ride where alligators live. And so that's our family on a National Reserve bike park. Or canoe in your backyard after the hurricane has turned a little pond into a large lake, right? Or do mud bogging, or just play in the sand. But being here in Florida, and these are just some of the animals that are seen in our neighborhood and backyard, with the exception of the rhesus monkey, which we had to travel a couple of hours to, brings me to appreciate this aspect of the country. And it kind of emphasizes that although you have different wildlife in your part of the country, they're all animals. And so my experiences are unique in healthcare to this part of the country and the landscape, but hopefully you'll take some pearls and gems that are relevant in your journey. So really for objectives, my goal is to perhaps place an argument that you probably already embrace, which is in an academic medical center, we really are a four-legged and not a three-legged creature. And so in that space, we will explore over the next few minutes some opportunities for physician participation and conversations outside of the clinic in the regulatory and payer space, kind of explore the role and experience of physician stakeholders and legislative advocacy, and then spend hopefully a few minutes looking at our journey to CMV legislation here in the state of Florida. And so, yes, the model we really have and embrace with the academic medical center is patient care, education, and innovation. And I would add that the fourth leg of advocacy along research, care, and education is actually quite essential. And without that, the model is really unstable. The ultimate goal, of course, with clinical care and education and research is providing the appropriate care. And appropriate care could be defined as the right care for the right patient, for the right problem at the right time from the right provider. And so we chase that with what we can understand, which has not been understood before, which then we can teach to those who are looking to learn what we know, but then taking that outside of where we practice to make sure that a wider group of the community and the country and the world have an opportunity to see what can be done and should be done better is where advocacy comes in. So when you think about Florida, Florida is the third largest state in the country. It's really kind of a two bucket, maybe three bucket, you could argue, state, right? So we have about 67 counties. Um, Believe it or not, most of them are urban, but you see some differences in the urban and rural nature. So the top half of Florida really kind of identifies with the Deep South. And then, of course, the southern part of the state has a strong Latino Hispanic urban flavor. But there are differences in per capita income in the urban and rural areas. There's a difference in the high school graduation rate. There's a difference, slight maybe, in employment, but certainly when it comes to risk for mortality and preventable hospitalizations, the rural part of our state has some challenges that we aren't seeing to the same degree in the urban area. You know, as you look at the two maps here, you see the large colored areas of higher population. Those are where educational centers are, et cetera. And then you see the map of the recent election to give you a sense of what Florida kind of feels like. Um, so 23 million, I know I'm talking to a California audience, so that isn't a big number for you all, but except for you in Texas, those would make the rest of the country say, wow. Our birth not rate, but our birth numbers have been in the 215 plus for the last decade or so. You can see 2022 is the most recent data there. But as we are seeing a growth in our population and in a growth in our live births, we are also seeing a growth in the distribution of children here that are receiving healthcare through a public aid source. So we've grown from 57% Medicaid coverage to now 2 out of 3 children in Florida with that coverage. And so with that background comes the institution that I work for. So I work for the Nemours Children's Health. And Nemours' vision really is to provide leadership institutions and services to restore and improve the health of children through programs that are not readily available, bringing to the community something that others would not have or cannot provide. And so Nemours really is more than just a Florida operation. We are a multi-state, multi-center children's health center, one of the largest pediatric integrated centers in the country. We have 2 freestanding children's hospitals, one in the Delaware River Valley, and then one here in Central Florida where I reside, where we have almost 2 million patient encounters over the combined sites a year, with approaching 1,000 physician employees, 8,000 employees, numerous trainees, and significant contributions in both revenue from clinical volume and external funding. Because of the footprint that Nemours has, they have intentionality in both state legislative affairs, but also we have a national office located in Washington, D.C. that really tracks interests that are affecting children's healthcare across the country. So here in Florida, about 1 out of 9 children are taken care of by the Nemours system. We have 9 hospital collaborations and 34 sites across the state. And if you look at that map to the right, you'll see that in Pensacola and in Jacksonville and Orlando. So really kind of the top 2/3 of the states are where we have our presence. Here in Orlando, we are one of the 4 freestanding specialty children's hospitals in the state, and our Medicaid volume is higher actually than all the others around. Nearly 75% of children here that we see come with that. Our emergency department visits are modest. Our outpatient surgeries are fairly robust. We have here just shy of $20 million of external research funding, and again, a substantial amount of medical students and trainees serving here as the chair of pediatrics or the pediatric center for the University of Florida's College of Medicine, University of Central Florida's College of Medicine, I'm sorry. So here in Florida, one last slide about that is what do we do? When you look at this, this is a measure of kind of the severity of a case mix index here in the state of Florida, looking at all the institutions that take care of children. We would rank third in terms of complexity here in Orlando at Nemours Children's Hospital. And then when it looks at our birth and neonatology combination or complexity as well, is up there in the top quartile. So hearing-wise, Florida has a lot of children and does a lot of good work and working to early identify children with hearing loss and at risk of those. And so our 136 Joint Hearing Commission recommendations, we do a fairly decent job when it comes to identifying these children. And then diagnosing them by 3 months of age has fluctuated some, of course, with the pandemic. But then we have a drop off when it comes to early intervention. Now, some of these numbers are a little inaccurate just because of charting errors, and we're transitioning into how that's managed. We certainly recognize a number of children don't necessarily follow in the state-based early steps program, but work with private providers. But still, it shows that while we do a great job of arguably identifying these children, there are gaps in the system that allow children to fall through the cracks. And we know, based on our research here, that kind of mirrors what Dr. Chan and others have done out west, that there are barriers that complicate timely access to care. This is a study that we published a few years ago that looked at about 12 years worth of data across the state, and it identified race and insurance status were significant barriers to children who would otherwise medically qualify receiving cochlear implants by the age of 1 or by the age of 2. Odds ratio of less than half in some of these areas that are here. Not only do we see that there's in some ways a perfect storm. This is some unpublished data from the CDC that looked at the likelihood and the birth prevalence of congenital CMV. And what you notice in these darker weighted states, a lot of them are in the Southeast, and that's where the percentage of children born with congenital CMV is higher. Normally, we would say that's 0.5%, but in some cases, especially in some of our Black and multiracial families, instead of having 5 per 1,000, we're seeing almost double amount for children in these spaces. And so as I started practice here, after a few years, I started to notice some thematic barriers that affected the practice when it came to children with hearing loss and hearing needs. And those are some audiology carve-outs where you have industries or insurers who would cover otolaryngology care, but not audiology care, or that there were different restrictions and limitation in the children that could receive cochlear implants based on insurance requirements. And of course, then there was the deficiency of CMV testing. I don't know if anybody recognizes this, but this is the Badwater Basin. Took a trip to summers ago out to visit you all in California. It was one of my not so stellar dad moments. We came out in July on a family vacation, hoping to do the Utah National Parks, but it didn't work out. So we did Death Valley, and my daughters will not let me forget that memorable experience. So with those kinds of thoughts and background, I asked myself, with these barriers, with these needs, why do we do what we do? And how do we inform ourselves about care that needs to happen? And I realized that it's a combination of things, right? I do what I do because what I've seen done, what I get compensated for, what different regulatory and legislative bodies allow me to do, and then we try to move that needle by what we can observe or discover with our research endeavors. But we know that there is this tension that exists when it comes to physicians and clinicians in directing what is in the best interest of their patients. And of course, I think we can soberly reflect on the events of the last couple of weeks with the recent loss of life of Mr. Thompson, but also in subsequent conversation, the pivot that Anthem took in kind of deciding that, limiting the amount of anesthesia that patients are going to receive at their level is probably not the space they want to be in. So who gets to make these decisions, right? Is it the physicians and the specialists in these societies, or the external forces that shape how and what we do? Certainly, we recognize that while there is a lot of perhaps debate about whether or not healthcare is a right, practicing medicine clearly is not a right. Our Federation for State Medical Boards has said as such. The practice of medicine is not an inherent right of an individual, but it's a privilege granted by the people of a state acting through their elected representatives. So what we do for our patients is something we can't take for granted. We just have a final voice. But how do we not lose that voice, and how do we articulate it in a way that can be appreciated? So this slide really got me thinking as I was asking, so then who determines care, right? Who decides what happens, when it happens, and for how long it happens to your patient? Certainly in the middle, you have the patient and or their caregiver if you're in the pediatric space, but payers, employers, private foundation and advocacy organizations, professional societies, credentialing entities, quality safety organizations, state agencies, regulatory and legislative boards, um, who has the loudest voice? Now, we don't have time, of course, to run through all of these, but some really do weigh in. We know that the 10th Amendment of the Constitution establishes state laws that protect the health, safety, and general welfare of their citizens. And then the federal government, in turn, turned that responsibility over to the states. And so states have a medical practicing act where they have established laws and regulations that govern the practice of medicine and then have empowered the state medical boards to kind of police that space. And that's what the medical boards do in terms of establishing standards of care for the profession and how they interpret these acts. There are a number of 3 and 4 alphabet acronym entities that make our lives fun, provide us direction and guidance at a federal level, but also at a state level. Here in Florida, we have the Department of Health and AHCA, the Agency for Healthcare Administration, which really provide the lion's share of work. Although there are others that are kind of listed in the bottom that overlap with care that's provided for patients. I believe in California, it's the Health and Human Services Agency and the California Business Consumer Services and Housing Agency that affect healthcare, health facilities, and providers in terms of regulation. So AHCA here in Florida really is kind of the chief policy and planning entity for the state. They have approximately a $35 billion Medicaid budget, and they are the ones that kind of oversee about the 50,000 health facilities here in the state of Florida, and take those fundings to come up with ways to provide care and quality care and regulation and inspections throughout our state. The Department of Health, of course, we all have those at all of our states. They also are a large entity with a different reporting structure through the Surgeon General, both of which, of course, report AHCA and with their secretary and the Surgeon General to the governor's office. But they are there to really, promote disease prevention and promote healthy habits of living, ensure healthcare workforce competency, and provide appropriate licensure and overseeing of facilities. And their budget here in Florida is about $46 billion. So 2 large entities that help shape what we do. But we have certifying boards, right? And as you look over time, the percentage of facilities that are requiring board certification has only grown. Between 2005 and 2010, the number of hospitals that required board certification went from 1 in 3 to about 80% in 4 out of 5. So we've seen a tremendous pivot in that, and that, of course, comes as no surprise. We in otolaryngology are seeing a growth of our boards too, of course, thinking of the new thyroid practice surgery board that is coming out on the tail of the complex pediatric otolaryngology board. Interestingly, our patients are looking at that and count the insurance you're provided, you're paneled by, only more important than your board certification and how they select care. And this was a survey published by the American Board of Medical Subspecialties. So if the physician has board certification, is second only to whether or not that provider is provided coverage in terms of who they are saying is important when they choose their care. This really needs very little interpretation. The Joint Commission, I copied a letter for those of you who are on the operational side. You'll laugh and chuckle when you think of what's been happening in our ambulatory space with trying to make our curettes, sterile for patients. But this is a letter to Dr. Denany from the Joint Commission at a request because of what's happening. But the Joint Commission, of course, is a major part of what happens in the healthcare space. as is the DNV, Det Norska Veritas, which is a little more international and global and focuses more on health systems and hospitals when it comes to accreditation for services at a little more frequent interval than the Joint Commission. Our advocacy organizations are stepping into this space. The National CMZ Foundation has put out some information, the Down Syndrome Global Foundation, about what they feel is appropriate care and timing for some of their patients. And of course, our academy with clinical practice guidelines, the ATA, the Joint Commission on Infant Hearing, or the NCCN guidelines that we pour over when we're talking about our Coomer board. All these kind of provide direction in terms of what care should happen. And so we step back and ask, as a physician, as a surgeon, is the narrative being read to me about what I should do with the care of my patient, or am I reading the narrative and saying, this is what should happen with my patient? Well, what does that look like? What does this look like? This is what it looks like. An email that comes across your desk that says Simply Health has closed access for their members to be seen in any audiology services that Nemours provides to their members. Unannounced, nice Monday morning email or whenever it came across. They've indicated now that 2020 Hearing Network is responsible for all pediatric hearing services effective the beginning of 2021. This applies to all our locations. And any hearing service that Nemours would like to continue will have to obtain an out-of-network prior authorization or have the negotiation of a single case agreement. So who is Simply and how does they affect our care here in Florida? Well, for us, Simply is a Medicare HMO that contracts with ACA to provide care for children in Florida. And they're one of our substantial payers. I mean, in the last few years, we've seen about 5,000, almost 6,000 visits, completed appointments between ENT and audiology alone. So these are substantial children who are relying on these carriers to get the access to the expert and subspecialty care that they need. And so now we had a bit of a crisis where you have to pivot. Who is 2020 the entity that they represent as an alternative to Nemours? Well, 2020 is a business that was actually started by an optometrist and an otolaryngologist to provide hearing health services in the state of Florida. Unfortunately, their scope is quite narrow, focusing primarily on adults. A lot of them have health providers that may be like in an area of a strip mall. And for tertiary care children's needs, it was really inadequate. But yet we were getting this directive saying you can no longer see these children. And so what did we do? Well, this took some creative thought. It certainly was very disruptive to our families. Some of them come from counties where there isn't even a provider that qualifies or is listed in the panel. So after numerous phone calls and encouraging the families to then become active and reaching out to Simply, and working with our managed Medicaid office and in ourselves having a conversation, calling up Dr. Solomon to say, how can we talk through this? Within 8 months, we were able to land on something that provided some benefit, right? And so now 2020's response is, yes, we want you to see these if this is where you're being directed by your insurance. However, there are some exclusions that are built into this. So for our young children, our medically complex children, our implantable devices, we have exceptions for that. And we feel that this has been a win in navigating some of the nuances of our landscape. So that's what it looks like on a payer side. What's another example? What does it look like? Lily was a 6-year-old who came medically complex with spina bifida, a tethered cord. She had hydrocephalus with a VP shunt, but also had Waardenburg and had essentially single-sided deafness. She had been aided conventionally since she was 2 years of age and was receiving negligible benefit from this. And she went through our multi-team evaluation and was deemed a candidate for an implant on that side. But we ran into barriers with her insurance saying that this was not indicated. And so her mother and Lily were quite disappointed. And it took some time to kind of work through this. But Lily's experience kind of led me to say, okay, there's some clear gaps in what is informing the policymakers at our payer status when they put out their guidelines that say this is what's considered experimental and this is what's considered standard of care. What is copied here is an email that really kind of illustrates what happened in that experience. ended up making a presentation. So Lily's Insurance is part of this parent organization, Centene, and on the next slide, I believe I show a little bit about Centene. But essentially, we reached out to Centene's high leadership to say we have plenty of published literature, we have FDA guidelines that are looking at single-sided deafness as not being experimental, but as valuable and as important in the space for children. And we know that your children and your panel are relying on you to provide good care. And so, how can we work through this? We'd had a handful of children who we were not getting paid that we'd already implanted. And to make a long story short, at the end of that conversation and presentation, they were able to acknowledge some things that we could do differently moving forward. Certainly, it took time, but that was a win again for our patients. And so, as I mentioned, Centene is a very large health insuring company with nearly 30 million patients in the country, approximately 1 in 15 individuals in all 50 states. Some of their subsidiaries here are Sunshine Health, and for us in Florida, they are the largest Medicaid payer we have contracts with. And so certainly being able to come to the table and talk to them about the science, about our shared goal of providing timely, effective care for children was important and rewarding. But that also led to another conversation, or perhaps I should say, in getting to the Centene conversation, we had some other stops. So working with the medical director for ACA to revise what are our state guideline policies, because these Medicaid companies and HMOs will look to what the state is providing, kind of the way we do in Medicare, to say what are our indications for providing coverage. And so his team and our team here, our audiology manager, myself, we really kind of rewrote what would be more appropriate for when we should look to aid a child, to implant a child, whether it's a cochlear implant or a BAHA. We're still working. This is a work in progress. We're still waiting to see that updated policy stamped. But I can tell you it was rewarding to receive this notice last year, where one of these HMO companies came out and said, we now have a revision in our cochlear implant policy, and unilateral single-sided deafness is allowed, and here are the criteria that are there. So we are extremely grateful for that, and Lily has been implanted. The work here is, of course, not just something that's happened in our isolated space. Here in Florida, working with the ACIA and the work they've done nationally, we have our state of Florida champions, and you'll see the individuals, the men and women, the audiologists and therapists, and myself who are looking to make sure that payers, legislators, advocates understand. And so finally, being mindful of time, what does it look like in the legislative space? Well, that of course is a little different because sometimes what happens at the political level doesn't always make good sense when you look at facts or finances. But for the congenital CMV entity, we know that it's impactful. We know that it's the most common cause of non-infectious newborn hearing loss. We know that it is a major player of disability for children. We know that it's more common than a number of the other more visible pediatric debilitating conditions that happen, that when you do get it, there's a high likelihood, 1 in 3 women who have it will transmit it. 1 in 5 children who are born with congenital CMV will have some type of permanent deficit or lasting condition. But the familiarity is still small, and fewer than half of our states are screening for this. When we look at the hearing loss related implications of congenital CMV, we have historically divided these children into symptomatic and asymptomatic, or disease and infection state. That's where the new language is headed. And we see that there is a higher chance of there being severe hearing loss in children who have quite involved disease. But both groups are involved. And so you have children who otherwise you wouldn't know develop hearing loss that can result in a severe to profound implant level qualifying type of entity. In 2018, when it first kind of was starting in this space, you'll see the 8 states in orange that had CMV legislation. The blue states were ones that were talking about it, and the gray had nothing. And of course, looking in the Southeast, it was all gray. But the situation is substantial because being a state that averaged 210,000 births a year, and if we took a 0.5% of those children having congenital CMV, you start to see that it's 1,000 children a year that are being added to that, approximately 200 or more of which will have some type of sequelae that's meaningful, approaching 300. And so these aren't just numbers to ignore when we think about what are interventions that needed to be provided early enough to have the greatest benefit to these children. And we recognized as we were looking at the CMV landscape that there were some notable attempts to get legislation passed that hit barriers. You'll probably recall in California the fantastic work that you did in getting these to a consensus at the legislative level, excuse me, but then having a veto by the governor that would have provided education and testing for CMV. Maine as well had a really thoughtful approach in looking at getting universal CMV screening, but we're told that creating a professional multidisciplinary panel to research and investigate this and come back to the legislature with recommendations was what they received. And so as we were sitting, and as I was sitting in Orlando thinking about, okay, how can we learn? The initial thoughts were not to attack a legislative solution for CMV, but to work with the regulatory route. But going on this journey of the legislative route, there have been a few little pearls that I've stored away that have been informative, and I kind of call them the 6 Bs, right? So being curious, meaning if you're thinking about engaging in a space that's going to become a law, thinking about the stakeholders, who is going to be seen as gaining and who is going to be seen as losing. In other words, who has the burden of work? Who is it going to cost more? Who's paying for this? And who has to pick up the slack? And engaging those individuals or those entities up front can really be helpful and thoughtful. Building a consensus, a diverse group, not just healthcare providers, but educators, parents, hospital executives. What does it mean? What would this mean in moving in this direction? Be realistic, except that there aren't always clear black and whites. There are lots of gray, and incremental progress is something that should be seen as a win. Being committed with consistent and discretionary effort, because certainly in a space where we are paid employees or even in private practice, this kind of work doesn't come with compensation. It comes with impact and lives changed. Be patient, acknowledging that the timing is not on your drumbeat, but it's on a much larger, grander scale. And of course, partnering with an expert. And for us here, it's been our government relations leadership team that have been absolutely essential in navigating some of these areas. And so this resulted kind of in what we call the Florida CMV Collaborative. And that is a working group of stakeholders who were really vested and committed to advancing better outcomes for our children in Florida with congenital cytomegalovirus. And you'll see that we have pulled folks from around the state, largely from our leading academic centers, but not exclusively, to talk about what are the best standards of care, how can we grow education, and how can we change the outcomes that are happening. We agreed kind of on going after the low-hanging fruit, increasing the educational efforts, seeing if we can keep the blood spot card as a way for identification. Here in Florida, that's kept for about 6 months or so. Is there any way that we can expand that in the event that the delayed onset hearing loss has a chance to determine what its etiology was? Targeted hearing screening would be the next step, and then eventually reaching to universal screening. And so how did we approach this? Well, we got, I think, pretty innovative. We brought in an expert, Dr. Al Park, one who we, of course, are familiar with, who's been a leader in this space nationally and internationally. And we asked him to provide a talk. But this talk wasn't just to our Department of Surgery or our Division of Otolaryngology. It was to our pediatricians in our Department of Medicine, but it was to our community. And so we invited family and patients and colleagues and competitors all to have a conversation about what does it mean to start on this journey here. And we had an enthusiastic response. Our work then pivoted to really take on a strong educational role, and we used all methods available. with conventional news media interviews, social media outlets. We worked with a collaborative of different clinicians to provide grand round talks around the state, partnering with other institutions in that space. We provided talks with our patients and our families. The ACIA was really helpful in that, interviewing these parents who have experienced this, sharing their story, but also sharing the data and what we do know in science. And then, of course, using the conventional scientific presentations, manuscripts, talks to provide information on what's happening in the CMV space. The conversation on a regulatory space was also very intentional, reaching out to leaders within the Department of Health in Tallahassee, but also more locally to see how can we pursue avenues that are going to result in early identification. We have two large regulatory bodies here in Florida that kind of speak to newborns, and that's the Genetic Newborn Advisory Council and EDDI. And so presentations from members in those meetings to grow awareness was taken advantage of. And then things changed a little bit. In October of 2021, we were notified that there was a senator, Senator Tina Polsky, who represents a district in the southern part of the state, was very interested in proposing CMV legislation. This came at a time when there was quite a bit of controversy around COVID and what that meant for Florida. And so all of a sudden now, what was being discussed in clinician spaces and in regulatory bodies became a conversation for the rest of the state. Just a little bit of perspective, Florida has a 60-day legislative period, so it becomes very intense, and it happens in Tallahassee. And Tallahassee, for us, is in the other part of the world. I mean, it's a 4-hour drive, not very intellectually stimulating drive, I should add, to that area. So it's a bit out of the way, and I can't say if that's intentional or not, but in order to have your voice heard, you got to go there. And so coming up with a strategy to accurately represent what we believe is in the best interest of our children became a priority. I can say not all good media attention and visibility is helpful media. And so being thoughtful about what was the message that was being driven, especially in the era of what we were seeing with COVID, became very important. We leaned into our established CMV collaborative to get perspective, partnered with our GR institution or GR teams at some of our leading institutions to craft legislative language with Senator Polsky's office, and then reached out to get bipartisan champions, both on the Democratic and Republican side, both in the House and the Senate. And once we had that, when we looked to provide stakeholders outside of clinicians to weigh in with this, I can't say that these ideas are all mine, and so I'm extremely grateful for what Jacob Horner, our External Affairs VP, who used to work in Tallahassee, has done in helping us navigate this space. Of course, also having institutional alignment was important and provided a depth and a pool of resources that, as you see, we continue to tap into. And so we and our team on different days made it a point to go and testify at these hearings. In order to get a bill through, it requires multiple visits in both the House and Senate side. And so myself, our chief of infectious disease, our chief medical officer in Jacksonville at the time, all made that trek to meet with various representative officials in their offices and testify before their committees. And it wasn't just a Nemours effort. Others should be recognized for the tremendous work, others who made the trip to Tallahassee to speak. And then, of course, partnering with our family organizations, Deaf Kids Can, and their work to bring children and parents there to share their experience in the faces of legislators was absolutely crucial in providing perspective for what was written down in the documents that were being proposed. Collaborations outside of our immediate clinician space with the Florida Hospital Association, Florida Academy of Audiology, Otolaryngology Head and Neck Surgery, the Florida chapter of the AAP, getting all of them to weigh in and vote support helped create a perspective that this isn't just a small group, but it's multiple folks saying, hey, we need to turn the tide on what's happening here in Florida. And so that journey required navigating through the regulatory committees, getting a legislative fiscal review, having bill sponsors, having committee hearings, 3 stops on each side, having a full chamber vote twice. And then, of course, at the end, having the governor's signature. But we were happy to announce that in February of 2022, the Senate Bill 292 was passed and became law. And essentially what that provided was targeted hearing screening, which we expected would affect about 10,000 children. So if children now fail their newborn hearing testing by 21 days of life, they are required to have some form of CMV testing offered to parents and then reported to the Department of Health within 7 days. It is also, in a perhaps unintentional way, provided more incentive to get newborn hearing screening done more timely, because now home births have a mandate to have their children screened for hearing loss, such that if there is a failure, we can identify CMV early. Birthing centers also have a mandate in terms of how quickly they need to have their children pursue CMV testing. But you know what? This wasn't the end. And so last fall, Senator Topolsky's office again reached out in conversation about moving the narrative. And so it was looking at, well, what can we go? Because we're looking at 10,000 children with hearing screening, but that is a small minority of what's happening in Florida. And so Senate Bill 168 was born. And once again, the same type of rigorous conversation, the same type of trips to Tallahassee to meet with elected officials, presenting information, partnering with families, partnering with champions and advocates to present how we can expand the reach of children who are deemed high risk for this entity. And so in the interim, the CMV Collaborative also grew, and we were able to expand those partnering institutions that were able to weigh in and offer support as we moved our narrative forward. We were again very blessed to have unanimous bipartisan support in both chambers, and we're able to send the bill to the governor's office, SB 168. We would call this targeted testing plus, where now not only is a child who fails their newborn hearing testing screen, but children who wouldn't be screened in time. So our NICU population, our medically complex population, whether it's surgical or cardiac in nature, who just wouldn't be tested for their hearing because they're too fragile or too early, have the opportunity to be, or not the opportunity, are now being required to be tested. So we know that early on. The initial bill passed as an unfunded mandate. This time we were able to get a CMV testing as a coverable reimbursing service, and then also bake in a way for children who have this diagnosis to be able to have access to early steps, interventions, and screenings. And so we can confidently state that through this journey, our needle has moved. If you look at the map on the left, the orange represents those states that had legislation in 2018. Now, 6 years later, you can see the blue represents those states that have CMV legislation. There is a state in the Southeast. There are numerous other conversations. You can see the light blue for pending legislation, and this is happening around the country, and we're happy to be a part of that conversation. And so where are we now? Well, we can say in 2023, there were just over 221,000 live births. Approximately 8,700 had failed hearing screening. We had over 9,000 CMV screenings. Note some of our institutions have pivoted to doing screenings in all of their NICU populations who they feel are high risk. So that's why the numbers exceeds what the newborn screening is. And we are seeing some of the concern positives come in. 2024 data is still being collected, but you can see what we're on pace in terms of screening rates to accomplish. Realizing that taking money from taxpayers is a privilege, we also want to think about, is this the best use of that money? And so we put a grant in, unfortunately wasn't funded this round, to look at what are we seeing and what difference does this make with early childhood developmental milestones and outcomes now that we are looking at targeted plus screening. So hopefully that will be kind of the next step in this journey. And then when it comes to hearing loss in general, where are we now? Well, you know, with these regulatory changes, it's a bit early to tell how that is going to rescape the landscape when it comes to intervention and timeliness. But looking at our own institution over the last 8 years or so, we can see if these graphs represent the age and the numbers of children who underwent the first side cochlear implant. We started our program in 2015, and you can see our numbers over the last few years. What's really encouraging, outside of the pandemic years, is where our first implants were, children who were well into their childhood, first, second graders. That number is dropping down now to around 2. Now, you can say that that is because we are more known and we have better processes, and that is true. But I think some of that also comes because we're able to help the system work better. And one of those is saying this is a service that's provided and covered, and both the regulators and the payers and the clinicians understand what is the information that needs to be brought to the table in a timely manner to have the outcomes we're looking for. And so in conclusion, just wanted to look at a few things that I think are important to kind of take away, right? There certainly are numerous voices in the space of providing care for patients. But the voice of the physician should be heard clearly. It's essential and it's unreplaceable. And part of that means that our voice needs to be brought to that, because if we're not there, who will speak for us? Ensuring the best care for our patients is no longer guaranteed by being a very knowledgeable clinician or a great surgeon, right? Effective advocacy is a critical skill. We've got to get into those rooms and into those spaces to say this is what needs to happen. Regulatory wins take relationships, relationship building. It takes thoughtfulness, rationale. You got to have a case, it needs to make sense, and we need to be realistic. Legislative wins take preparation, they take partnerships and patience, trying to understand what are some of the priorities for what the legislative body is facing. And then, of course, it takes compromise, and perhaps I should add a bit of luck or blessing, however you want to look at it. And so it would be very short-sighted for me not to mention the leaders in the government relations, the legal team, our managed care teams, our administrators, and some of our clinician leaders who have been so instrumental in navigating these spaces which require discretionary time to make cases for moving care outside of directly laying hands on children here in Florida. And this is a group of our team members last year at our holiday party. So with that, thank you for an opportunity to share our work, our experience, and we know that amazing things are also happening in your space. Michael, hopefully I left a little bit of time there, but I'll turn the microphone back over to you.
Thank you so much, Dr. Pritchett. That was a phenomenal, truly inspiring presentation about kind of the way that physicians can become advocates for their patients. We do have some of us that need to sign up for Tumor Board or Sinus Conference at 7:30. So I'll, for those that need to leave, please feel free. But for those that are able to and would like to engage and stay, I'm sure Dr. Pritchett, if you're able to have a couple of minutes, would love to answer some questions. So feel free to raise your hand and we'll call on you and we'll go from there. Thank you.
Sure.
Dr. Pritchett, I can actually start as we're waiting for some questions if funnel in. One question I have is about what you thought the greatest barrier to implementation of this legislation was. And one kind of other sub-question on that is, did stakeholders or Congress ask you about the financial side of things and how you kind of engage with that, or what you think, even what sort of engagement there is required for that, for things that we think should be like needed parts of care, but maybe is
Sure.
hard to kind of justify financially. Thank you.
Absolutely. So I'll answer the first part, the last part first. So we personally didn't get a lot of question from the legislative body about cost, but that's because when there is a bill that comes through here in Florida that is related to healthcare, the Department of Health is required to put together a fiscal kind of summary about what they believe that impact would be. And so what we ended up doing was kind of working with the DOH and looking at that. It's important to acknowledge what you know and what you don't know. And we don't know everything, and that's okay. But we know enough to say, here's what we think is likely. And so that was what happened in that process. There was a fiscal analysis that was presented so that the legislators had an idea of what the price tag would be. In terms of barriers, um, there were numerous, and I tell you, I was nervous because there were politics all around this, right? There was the politics of you're in a state that's having a lot of difficulty and split opinions on COVID. And that was part of the prepping we had in going up to Tallahassee, being careful what we decided to do and what we decided to say. There was also politics between our major sponsor and the Department of Health and the Surgeon General. There was a falling out between Joseph Ladapo and Tina Polsky. I don't know if you all will remember that, but it was a masking related visit. And so she being the sponsor and he being a person who needed to give a stamp, that also was a really kind of a potential thin ice moment when we wondered what would happen in that space. I think, though, more practically, a big barrier is probably just implementation. And for those who are making decisions that we should move forward into this, knowing that when you make a law, you got to be able to have some way of not just enforcing it, but enabling people to accomplish it. And there are so many healthcare entities in Florida that are in the mix of care delivery. We don't have a certificate of need anymore here. And so there is a lot of I don't want to say a lot of variation, but um, the Department of Health got a sense as to how much work it took to help the 150 some different birthing centers get up to speed on this afterwards. And so I think some of that is just what does it look like to roll this out in some of the most rural, unsupported counties, as well as your big urban centers, was probably part of the question in that.
Got it. Thank you so much. I think we have a question from Dr. Chan.
Yes.
Hey, Cedric, thank you so
Ellen,
much.
hey, man.
Awesome to see you.
Like,
Um, and yeah, thanks so much for your talk. It's so inspiring to hear like all the different levels that you have worked on for this advocacy. One question that comes up a lot for residents and faculty is like how people can get involved, right? Um, Oftentimes advocacy feels very reactive, right? We sort of put out the fires that come up, whether it's an insurance denial or someone asking for policy, input. Um, but how if we're just here, how do we be more proactive in setting ourselves up for advocacy opportunities or creating those opportunities?
well, that's a loaded question, and I think you're right. Some of these situations we don't really get to choose; we're just thrown into them. Um, but the other is, I think, acknowledging that we are the experts on these entities, and there are people whose job it is to be experts making decisions. And so being thoughtful about saying your job is to make the decision. I want to be a resource so that you have good information, right? And I think adopting that mindset is a paradigm shift, right? And that mindset can apply whether it's within our department, within our organization, within our community, within our state, within our country, saying, there are people whose job it is to make those hard choices. That's not me, I'm glad that you're in your space, but I do want to make sure that because I know it's going to impact at least this group, you need to have good information, right? And I think as faculty have our areas of expertise, realizing that we are the experts in that area. As trainees, as we think about where we want to go, say, okay, hey, I'm not only taking what's best practice, but how do I inform the constituents that I will be serving? This is why we do what we do, right? And so that can take a number of appearances, you know, but I think every crisis is an opportunity, and so those denials and appeals, especially if you're seeing themes, that's where to start, right? Um,
Thanks. Thanks, Cedric. So, so nice to see you.
Good to see you too, man.
The orbit being pulled down, and etc. Dr. Pritchett, I'm not sure if we have any other questions, but I just wanted to thank you so much for coming to speak. Really kind of your experience in Florida is inspiring, kind of, for me personally, I think, but for many others in the residency and for our faculty. So thank you so much for being here. And it was so wonderful to meet you in Vancouver, and hope to be in touch in the future as I move forward in my own career. So thank you so much.
Absolutely. Thank you guys. Have a wonderful holiday season. And, I wish you all the best in the great work you guys are doing as a flagship institution in our country.
Thank you, Dr. Pritchett. Take care.
Happy holidays.
Happy holidays.